So with that, I will transition over to my colleague we're going to move to some case-based discussion so we can hear, how do we utilize these data to make decisions?
Shannon, that was an absolutely wonderful summary of past data, current data, and thank you for that great presentation. It's always a pleasure to work with you and to be talking about patient care with respect to ovarian cancer. So we're going to talk about a case, a newly diagnosed ovarian cancer patient, BRCA wild type, HR deficient. So this is patient's a 49-year young woman. She's African American. She has a chronic hepatitis B infection and mild hypertension. Mother died of breast cancer, and mother's side of the family had ovarian cancer at age 65. CT scan shows ascites, bilateral adnexal mass is 8 centimeter. She has an elevated C125 to 285. She was seen by GYN Oncology, underwent exploratory laparotomy, followed with an omentectomy, bilateral salpingoophorectomy, pelvic lymph node dissection, appendectomy, and resection of pelvic nodules, and was optimally bulked to microscopic disease or to a no gross residual disease to microscopic disease. So I think this, with how Dr. Weston has really kind of highlighted some of the testing and some of the stratification, what testing will we order at this point? When do we typically test for BRCA1 and 2 mutations? Do you test for somatic mutations in the tumor? How do you test? And then are you routinely testing for HRD? So, to me, I can start out by answering these. And what I would say is that at this point, I think I don't want to say confusion, but there's a lot of options. What I would say is somebody with advanced stage high-grade serous ovarian cancer, we know that the NCCN guidelines, ASCO, SGO, say that these patients should be referred on for germline testing. So to me, in our office, we're referring these patients to our geneticists, and they're getting germline panel testing. Also, what we're trying to do is if patients are BRCA1 or 2 negative or panel test negative, we're starting to send most of the tumors for HRD testing with the Myriad test. And that obviously will look for somatic mutations as well as do the genomic instability score. So we don't do things together. We do them sequential in that we'll test the patient, then test the tumor, and then use those results, because I think, in my opinion, for this patient that's being treated, really she needs surgery plus platinum-based chemotherapy, bevacizumab if you'd like, and then we'll have to kind of decipher how we're going to do her maintenance therapy.
Mm-hmm.
So really, in the absence of BRCA1 and 2 mutations, HRD status may give us more information about the benefit of PARP inhibitor therapy. I'm a firm believer of this. I think information is very important. So to me, this is why I do like the HRD test. And I also think that when you talk about an HRD status, you really should probably describe in your progress note, how are you defining that HRD status? Is it a BRCA germline mutation? Is it a somatic mutation? Is it a genomic instability score from Myriad? Is it a Foundation LOH score? And I'm sure there are other companies such as Tempus that may come out with an HRD score at some point. Caris does say they have some HRD testing, as well as Ambry Genetics does do some next generation sequencing. So there are many tests out there. So I think it's really important that when you say somebody is HRD or has H homologous foundation deficiency, you kind of define that. I think that's very, very important, because all tests are not created equal. And again, this is the two tissue tests that are available. Myriad myChoice. Again, you can see they're the companion diagnostic for niraparib, first approved with Quadra, and now approved with Paola, and again, Foundation Medicine. I think if you dig a little deep into how these tests were developed, Myriad myChoice, again, has the 3 components you can see listed below: loss of heterozygosity, telluric, allelic imbalance, and large-scale state transition. So to me, they have these 3 scores that they put together to try to help capture BRCA-like tumors. And so you heard a lot of discussions at SGO about the different score ranges and things, but to me, the Myriad myChoice was designed to grasp or to capture BRCA-like patients. The Foundation Medicine score is an LOH score, and when you look at how that test was developed, they really looked at that test, and it was developed alongside using rucaparib in Ariel 3, I think it was. So it was a test that when they looked at the percentage, they tried to guide the percentage cutoff by how patients responded on treatment. So the tests were developed a little bit differently, measure HRD slightly different. So I think that how you test folks is important, and how you describe it's important.